have now. So even more, way more students and way more students graduating. And it rained like 2 years in a row. And then when it was in winter, it was like ice cold always. And so they worked on an agreement with UIC. So that's why it's at UIC, to have graduation there. It's also warm, it's warmer, and the timing is just based on when UIC is available, to an EIU. But yeah,
Even even in the winter, it was outside.
it was outside in the winter back in the day.
Well,
Oh.
I can't imagine that. That's
Yeah, I
crazy.
mean, like a day like today,
Oh,
like, oh
it'd be
no.
impossible. You can't sit through this. This is ridiculous. So, um, so yeah, we'll wait a couple more minutes for people to join because we're missing who's won. It was Maricela. Um, yeah, so that's why it's at a weird time. But the nice part is by the time you're done, it's a good time to go out for dinner, you know. So early dinner, but with family or go to a family's house. Yeah.
How long do graduations typically last for?
Well, so they call up everybody's names that are graduating that year, plus you have the keynote speaker and the valedictorian give a talk. So there's a process. It's usually about 2 hours. It's pretty quick relative to other places I've been. Um,
Yeah, okay.
so when I at Northwestern, when I got my PhD, they have the big ceremony, which is at Ryan Field. And that's where the keynote address was, and then they had each class stand up, and those with the PhD got like front row seats. It was kind of nice. And our keynote speaker at the time was Stephen Colbert.
Wow.
Um, and he was really good. But like actually one of the best graduation ceremonies that I've ever heard, like the keynote speaker was when my wife graduated from Roosevelt University, and the guy was an accountant, and it was so good. His speech was awesome. It was on point. It was funny enough, but it was really about the graduates, and he was an alum. It was just really good. So even if you have big names, and I've been at ceremonies with really big names, even at NEIU, we've had what's her name? She very famous for West Side Story, um, both the play and the movie. Do you guys know who I'm
Rita
talking about?
Moreno?
What?
Moreno?
Yeah.
Okay.
So we've had even very famous people, and their talks were really good. But again, this accountant was better. So yeah. So yeah. Um, so yeah. It's so if I highly recommend going to graduation because it's really about your family and the people that supported you. So all right. I think most of us are here. I would like to get started. To remind you of the rules, you have 6 minutes. I will be cutting you off at the 6 minute mark. I will let you know who's next, but the nice part um, is that we do have a little bit of time as we transition because it expected that at least one person gets to ask a question and everybody has to ask a question. Okay. There's a couple of people visiting with us that are taking incompletes. And you do not have to ask a question, but if you do, I'll make sure that somebody else gets to ask a question. Um, the point of the question is if you don't know the answer, say I don't know. It's okay. But it's really, just getting into the practice of asking questions and okay. Um, we should have plenty of time to get through everybody within the timely manner. And I see we had something in the chat.
Is it okay if I ask a question in the chat? This is Lachey.
Yeah, I would rather you do it actually by raising your hand and then
Okay.
ask. Yeah, please, Lachey.
Okay.
And congratulations, Lahara, to your mom. Yeah, family graduating is huge. So, um, all right. So, Maricela, you are first, actually. You're first victim. We're starting in the middle of the alphabet. And H is, even though it's not the middle, it's
Oh,
usually the middle.
okay. That's fine.
Okay.
Let me
So,
just share my screen.
yeah, let me make sure everybody can share.
I'm sure he did some statistical analysis to figure out.
Actually, you know what I did was
The
there's
middle.
15 people in the class. I went down to number 8 alphabetically and then went back and forth from there. So, so alphabetically, you're number 8. There was no math. It was literally numbers. I'm not that smart.
Okay,
But I wish I would
so
have thought of that.
I'm gonna try my best here. Let's
Well, that's all we ask.
see. Okay. So, do you guys see my screen?
We'll let you know when we're
Okay.
ready, okay? You might want to click your screen.
You guys see my screen,
It says your
right?
started screen. It says ask. There you go. Now
We
we
can
can
see
see.
it now.
All right, go ahead and get started. Marcelo, you can go start now.
Okay. What do you mean?
Go ahead.
Okay. So this is my title is preeclampsia and severe okay, preeclampsia and severe
Marisol, so I'm gonna pause you for
a
1 second.
public health concern.
So you might want to stop sharing your own image.
So
Marisol,
this is my introduction.
uh, so what's happening is
I stopped sharing.
yeah, you have a
Is
bad
that
connection.
fine?
So if you stop sharing your own image, that'll help you with your feedback. Okay? So we don't have to see your face. I mean, we'd love to, but we
How
don't
do I
have.
do that?
So
I
under
don't know.
video, if you just say stop video,
Oh, okay. Videos.
it will use less bandwidth. Do you see where it says
I don't
video?
know. Yeah, I see the video part, but it says I'm clicking on video. Okay, there you go.
Okay, now share your screen and it should hopefully work better, okay?
Okay. Do you guys see it now?
Double click again.
Do you guys see it?
No, it's coming though. Click on your screen. Now we can see it.
Is that fine?
Yeah, it's perfect. And we can hear you better too.
All right. Okay.
Go ahead.
Okay, so preeclampsia and severe maternal morbidity. So my introduction, what is preeclampsia and severe maternal morbidity, which is also stands for SMM. Pressure during pregnancy affecting organ systems, unexpected outcomes causing severe health challenges. There is being preventable. So the data I did my analysis from, so it's based on 408 SMM cases of severe maternal morbidity in Illinois to 1,595 live births, the hemorrhage 48.3%, the preeclampsia and eclampsia 20.3%, the infection sepsis is 7.1%. So these are the main severe ones. And the delays are in assessments and treatment, communication gaps between healthcare providers. Recommendations is to enhance the diagnostic criteria for hypertensive disorders. So the objective from my is 95 confidence interval for hemorrhage related to severe SMM cases. So this is based on the 408 cases, the 48 hemorrhage related SMM cases, the confidence level 95%. I did use the R software, so that is the calculation there. The proportion of the hemorrhage related SMM is 48 over 408, which is 11.76%. The 95% confidence interval is 0.4318 and 0.5282. And the results is that 95% confident that the true proportion of the hemorrhage related SMM cases lies between 43.18 and 52.82. So then just to summarize a power analysis, the objective here is to estimate the sample size required for analyzing the hemorrhage related SMM with the 95% confidence interval. Here are my calculations. I did use the R software. The hypothesis testing. This is test of proportion. My score negative 0.686 and the p-value of 0.508. So the proportion of hemorrhage related SMM cases is between 43.18% and 52.82%. The hypothesis test shows that there's no significant difference between the observed and hypothesis proves that the sample size is sufficient to detect meaningful differences. So this is a different study that I found for Ghana quality. So this is a qualitative interview, and part of the study was 22 obstetric care providers, and so there were some challenges there in managing preeclampsia in low environmental settings. So they lack medical equipment, limited diagnostic tools, referral delays, and skilled providers. So there's cultural and systematic delays in seeking care. So there's more data insights from this. There's 15 deliveries affected by HDP, 10,000 deliveries annually at the study hospital, and barriers identified by 22 obstetric care providers. So in the study, they provided this figure, which are the challenges to diagnosing and managing preeclampsia in a low resource setting. So this is the patient level, provider level, and system level barriers to preeclampsia and diagnosis and management. And this is a different study data. Severe maternal morbidity index, population level, surveillance at delivery, hospitalization based on hospital discharge. This is a table summarizing for severe maternal morbidity indicators based on the study. This is on some more information data I got from the CDC. It's the highest rate recorded since 1965. The age disparities, woman age 5 deaths per 100,000 live births. The woman age 25, 31.3 deaths per 0.4 deaths per 100,000 live births. It might be short.
No, that was perfect timing. Literally, my alarm just went off. So,
Okay.
all
Did I
right.
stop sharing?
Who has a question for? Yeah,
Did I
you
stop
just did.
sharing?
Yeah,
Okay.
you can see when you're sharing or not, by the way. I know it's sometimes hard. All right, who has a question for Marcella about the preeclampsia?
I have a question.
Yeah,
Um,
go ahead, TR.
so I was diagnosed with preeclampsia at 26 weeks, and it was because the protein levels in my urine was high. So for my second pregnancy, with my history, they knew to prescribe me baby aspirin to prevent me from getting preeclampsia again. But I would like to know, like, what would need to be done to make sure hospitals are staffed to properly deal with a situation like that. If somebody is pregnant at 26 weeks and get diagnosed with preeclampsia, because my initial hospital was West Suburban, but I had to be transferred to Northwestern.
So I think like for that, I think for hospitals, they should like have like different strategies, maybe like early screening and or like maybe like accessing like the records, like medical history, like the blood pressure and any like signs of like risk factors. So like having that in place, like in the emergency rooms or even like in the hospital appointment clinics. Um, but yeah, I think like really like early screening and just like monitoring like the blood pressure and like the urine.
Mhm.
And as far as like the aspirin, I think I don't know, like there should be like an intervention to like the risk of like preeclampsia.
Mhm.
Um, but I really don't know.
Okay.
That's all I
And okay, I got one more question. So we're doing your research at what week, at how many weeks is it normal for someone to like be diagnosed or have preeclampsia? Like, did you see any relationships with that? Is it normally like 26 weeks? Is there more people diagnosed with it
Um,
at 38 weeks?
yeah, so like preeclampsia, it's like typically developed like at the 20th week of pregnancy. But
Oh,
some cases, like I think it's 24 weeks.
okay.
Thank you.
Interesting. Those are great questions. Yana, I know you had your hands up, but you'll be able to ask a question for Ananth next, okay? And you can always, by the way, you guys can drop questions in the chat too, so you can answer it through there. We just only have one time for one person at a time, okay? So Yana, drop it in the chat, and Maricela can maybe answer it while Ananth is presenting.
Okay, will do.
Thanks. Ananth, go ahead. Yeah, yeah, share your screen just because I didn't get everybody's presentation in time to make it a single deck. Yeah, no worries. Ooh, Yana, that's a really good question. All right, we see your screen, but not the presentation. I now want to be where the northern lights are.
How about now?
Yes, we can see it now.
Okay.
You're good to go, okay?
All right. Oh wait, no, hold on. Okay, I'm ready. Hi, my name is Nant Prabhu. My presentation is titled Global and Local Perspectives on Contraceptive Use Among Young Adults. It focuses on a campus survey analyzing emergency contraceptive vending machines conducted as part of this biostats course at NEIU. The survey analyzed 11 out of 55 potential comparisons, revealing one weak trend, which was differences in vending machine convenience preferences between international and domestic students. While the small sample size limits validity, this cohort is the first of many planned to gather broader insights. Future analysis will examine unstudied comparisons, helping NEIU student health services address students' needs including health, product availability, privacy, affordability. This survey highlighted student interest not only in contraceptive products, but also in non-contraceptive items like the first aid supplies and hygiene products. Continued data collection will help identify health disparities and guide funding decisions to better serve NEIU's diverse student population. This research is essential because it identifies student preferences for health products and services, guiding improvements to accessibility and convenience. It highlights potential health disparities between domestic and international students, informing decisions about the privacy, location, and affordability of these products. Ultimately, the findings provide valuable data for enhancing student health services over time, which is exactly what the purpose of a needs assessment from evaluation is all about. The top graph shows that the convenience of vending machines offers privacy in a closed-off nook area and also offers just enough visibility so students actually know that it exists. The bottom graph highlights it features two important facets to ensure that the emergency contraceptive Plan B is available anytime and can be afforded by students who need it. Power analysis was performed before data collection to set expectations for the study's design. The primary goal of this analysis was to determine the appropriate sample size to ensure sufficient power, ideally 0.8, for detecting meaningful effects. Chi-squared tests were used to assess relationships between variables with particular focus on the relationship between multiple pairings of the 10 levels of measurement. The p-value for this relationship fell between 0.05 and 0.1, indicating a potentially weak but meaningful association between national status of students and preferred location of contraceptive vending machines. A medium effect of Cohen's W equals 0.3 was chosen, indicating a moderate strength of association between the variables. Based on these parameters, the power analysis suggested that 133 respondents were needed to achieve 80% power, ensuring a high chance of detecting real effects. This sample helps reduce the risk of type 2 errors, where we might fail to detect a true relationship between variables. By calculating sample size ahead of time, we aimed to ensure our study was statistically sufficient, making the result more reliable and generalizable. However, due to convenient sampling and anonymity concerns, the actual sample size was much smaller than expected, with only 8 respondents. This smaller sample size limited the study's statistical power, possibly affecting the ability to detect significant relationships and emphasizing the need for careful consideration of sample size and methodology. The data presented here comes from one of 10 survey questions focusing on students' health product preferences for vending machines. The graph shows that pregnancy tests were the most requested item, with 5 mentions, followed closely by hygiene products and first aid supplies, each with 4 mentions. Other items like drug prevention kits, various types of condoms, and dental dams were less frequently requested, suggesting more specialized needs. Data was collected through convenient sampling using QR codes, access on the vending machines, and tabling events in NEIU Student Union to reach participants. Importantly, the survey maintained anonymity with no personal identifiable information or tracking of the respondents. One of my graphs and acquired data was vaguely similar to the context of research from one of my sources in my literature review. Beckstein retrieved his data from college students in 35 states and Washington, D.C. Students at NEIU, by comparison, gave the most priority to wanting pregnancy tests, with the next three products being non-contraceptive health products. Non-NEIU students in Beckstein's research used and wanted to use hormonal intrauterine devices, condoms, and the birth pill, all over all other forms of contraceptives. All other forms of contraceptives received less priority by all college students in both studies.
That's time enough.
Okay.
I know that I think your like slide is
Yeah.
Okay. All right. Do we have a question for Ananth? We have to. So
I have a
Oh,
question.
should I put this slide back on?
no, you're fine. You're fine. You can stop
okay.
sharing. Go ahead. Samaya, was that you?
Yeah, that was me. So for your power analysis, I saw that you had 133 respondents. So is that like the number you would need for a survey that you would want?
Yes,
Oh,
that's the minimum number to actually have substantial results.
okay. Okay. Thanks.
Yeah, that's good. Tiara, you're next. Thank you, Ananth. And yeah, it's kind of interesting. It's always fun working with data that's related to your institution or where you live.
And also, since my concentration of public health is health education, it was extremely relevant for me
Yeah.
in the context of the needs assessment and evaluation.
I'm doing it now. My computer just been taking forever to load.
Yeah, you're fine. We're being patient. Yeah, it was interesting. I agree with what Samaya's saying as we're waiting for Tiara to get her computer up. How the second highest preference was for hygiene products. Yeah, yeah. It's I'm
Anand, were there other resources? No, sorry, go ahead. I'll
no. Go
ask.
ahead. Go ahead. You
Were
can
there
go.
other resources on campus available for them to retrieve these things like a gift shop and like a store in on campus as well?
It was. You mean how we reached out to respondents?
What were
Or
there was there any information about other resources available to get these items as well on campus?
oh, it's specifically through the nurses at Student Health Services and the vending machines.
Okay.
At the Nest and the Student Union. Only 3 locations.
By the way, that's still actually pretty high for an institution like NEIU. Just so most people, I don't know if other people have been at other institutions, but like when I was a grad student at Northwestern, it was almost inaccessible except if you went to the nursing facility, and like that was only in one location throughout all of Northwestern. So it was quite inconvenient for like those type of resources. So it doesn't mean that we shouldn't have it at more locations, and I believe we should have it in every building. So
Yeah, I revisited my Harper College recently, and they actually have some similar stuff going on, just like we do with the health services.
yeah, and we've been working with Harper College. So yeah. All right, Tiara, go ahead. You're our next individual.
All right. Hey y'all. So my name is Tiara Nico, and I'm going to be presenting on hepatitis B virus infection. Collecting data is important for implementing effective actions to manage HBV and reduce transmission rates, hopefully by gathering the accurate information on risk behaviors and demographics. Public health professionals can identify the high-risk populations to develop strategies and interventions. Hepatitis B is a liver infection caused by the hepatitis B virus, which can result in acute and chronic infections. Chronic infections can lead to severe complications such as cirrhosis, which is scarring of the liver, and another complication of chronic HBV is hepatocellular carcinoma, which is a liver cancer. HBV is highly transmissible and can survive on surfaces for up to 7 days, causing infection if entered in unprotected bodies. The incubation period ranges from 30 to 180 days and is detectable in blood within 30 to 60 days post-infection. And here's a visual of some of the symptoms. The most common transmission is mother to child during childbirth. Perinatal transmission is responsible for about 50% of the infections. And in Illinois, healthcare providers must refer pregnant women that test positive to hepatitis B surface antigen to a local health authority within 7 days to receive counseling and contacting their partners to be vaccinated. Most symptoms are asymptomatic, and that's partly why people don't get tested for, because they don't, it's asymptomatic. This research will allow an understanding of barriers that exist when accessing healthcare and prenatal care, especially for vulnerable populations. I know it was men and pregnant women. New and existing interventions can improve health outcomes to reduce the prevalence of chronic HPV in the US and globally, especially in developing countries. I want to support broader healthcare goals by increasing the rates and reducing perinatal transmission, educating men and other communities about it to achieve better health equity and reduce the disparities. A triple panel test is a test that they use to detect the infection status, the vaccination needs, and the components of the testing is the hepatitis B surface antigen, total antibodies to hepatitis B core antigen, and hepatitis B surface antibody. And by implementing those tests, that we could be able to have more complete records when getting more data. So this table shows how to interpret the combination of laboratory results, and understanding these markers can help clinicians determine the stage of infection, potential for transmission, and the appropriate management strategies from this outcome. Infants are exposed to HPV at birth should receive the first dose of hepatitis B vaccine and hepatitis immune globulin within 12 hours of birth. Complete the vaccine series and undergo post-vaccination serologic testing for hepatitis B surface antigen and hepatitis B surface antibody between 9 to 12 months of age, and then 1 to 2 months after the final dose. Without these measures, chronic infections can develop in about 90% of the infants, compared to 25 to 30% of children who acquire the HBV infection between the ages 1 and then 10% infected after the age of 5. When I was doing my research last year, 55 infants was born to infected mothers. Most of the infants, 52 of the infants completed their testing within the first year, and then 36 continued to do the post-serologic testing, and only 1 got diagnosed with HBV. Viral hepatitis B is a significant global health issue, ranking as the 7th leading cause of death worldwide, within an estimate of 254 million people living with it. 1.1 million deaths was contributed to this in 2022. It impacts the regions of Western Pacific and African. In the United States, 600 individuals were affected with it. I just want to show the globe. So the World Health Organization, like I said, Western Pacific and African regions, there were 97 and 65 million that were chronically affected. And in Southeast Asia, it was 61 million. And in Western Pacific, it was 15. 11 million was European regions. And in the Americas, it was 5 million. Okay. So the rate of reported cases of acute hepatitis B are consistently higher among males than females during 2005 and 2020. During 2011 and 2019, the rates remained stable, ranging from 1.1 to 1.3 cases per 100,000 among males, and 0.6 to 0.8 for females. Compared to 2019 and 2020, the rate declined 38% among males to 0.8 cases per 100,000 population among the 29% for female cases. When doing my, hopefully go to the next graph. Okay. So I created this data because this was the total deaths that was listed for males and females in the United States. So the males are 2.5 to 3 times more likely to die from hepatitis B. The male rate stayed between 0.65 and 0.66 per 100,000, and then the slight increase in the confidence interval, which aren't any significant changes over time. The female rate stayed low and steady, but although, and I think it was 2020 through 2018 through 2022, you can see that the female deaths are constantly increasing, but their rate remains the same during the 5 years.
That's time. Sure.
Oh, sorry.
No, it's okay. It goes quick. So,
Okay.
all right. Thank you so much. And it's a hard topic because hepatitis B is so old, but there's so much to study with it. Question.
I have a question. Can you hear me?
Yeah, Zahara, we can hear you
Yeah,
just fine.
I can hear you.
Okay. So how did they determine if a baby was exposed to hepatitis in utero? I'm
What
sorry if
did
I
you
missed
say?
it.
You said how did they determine if the infant was infected in utero?
Yeah, like while she was pregnant.
Oh, they would test the mother to determine if the mother was infected with hepatitis B, and if she was, then that's when they would immediately vaccinate the child after birth, and then 12 hours after that, and then they would have to continue the series until they complete the 3 parts of the vaccination. But I feel like that's a barrier too, because most people don't have access to continue with appointments to be able to keep up with the vaccination for their infant. So I think that's one of the barriers too. But since the vaccination in the 1982, infants that was born after that, it was a decline from that year. But I couldn't get to that chart. Sorry.
No, you're fine. And
Oh,
Yana
thank you.
mentioned the swab, just so we know. And not, you can ask a question on the next person, as Usman's getting her presentation ready. But yeah, they test every woman for hepatitis.
Yeah, I just really want to figure out like why are the male rates are higher than the female rate.
Yeah, that's a good question. I bet somebody has a study somewhere. So,
Hmm. That is a good question.
it's a really good question. All right, Usman's gonna be talking about water fluoridation.
Yes, sir. Can you guys see my screen
Yes, we can.
now? Okay. Should I start?
Yes, please. Go on in.
All right. Hello, everyone. Today I'm presenting the continuation of my previous project, and I will focus on how community water fluoridation impacts dental caries prevalence in both children and adolescents, specifically comparing fluoridated and non-fluoridated counties. So, what is the dental caries basically? So, it is basically a tooth decay that occurs when bacteria in dental plaque breaks down sugar from food and drinks, producing acids that damage tooth enamel. If left untreated, caries can lead to pain, infection, and even tooth loss, making it a serious health concern. In United States, caries affect 52% of children aged between 6 to 8 years and nearly 100% of adults at some point in their life. But there is a simple and a very cost-effective solution to prevent dental caries, and that is community water fluoridation. By adding just a small amount of fluoride to our water supplies, we can protect teeth from decay and ensure better oral health for everyone, especially those with a limited access to dental care. And the results speaks for themselves. There have been many studies published on the benefits of water fluoridation, and one of the most recent studies by Slade et al. In 2018 showed that the children in fluoridated areas experienced a 30% reduction in primary tooth caries and a 12% reduction in permanent tooth caries compared to those in non-fluoridated counties. Research by Slate et al. Showed that children in fluoridated areas um, experience like 30% reduction, which is a big thing. And similarly, Metzau et al. In 2020 also found that the higher fluoridation levels significantly reduce caries prevalence in adolescents, particularly in the underserved areas. So this slide shows that the comparison of dental caries prevalence between the fluoridated and non-fluoridated counties based on the data from Slade et al. The study combines the findings from National Health and Nutrition Examination Survey and the CDC Water Fluoridation Reporting System. To measure the caries prevalence, we use two standard indicators. One is DFS and the other is DMFS. So what does DFS stands for is decayed and filled teeth, which we normally do for children under 2 to 8 years. And DMFS is decayed, missing, and filled surfaces, and we normally do it for adolescents between the age 6 to 18 years. These metrics captures the extent of dental caries in each age group. As you can see, for the children aged between 2 to 8 years, the average DMF was 3.3 in fluoridated counties compared to 4.6 in non-fluoridated counties. Similarly, for the adolescents between the age 6 to 17, the mean DMF is 1.9 in fluoridated counties compared to 2.2 in non-fluoridated counties. This data clearly illustrates that the community water fluoridation helps reduce dental caries prevalence in both age groups. This table also summarizes the same thing, but we have added the confidence interval in this and with the p-value. Uh, the confidence intervals basically tells that true value lies between these two values, the true mean for the population. And in all the cases, it's in between these, like 3.3 is in between this 2.8 to 3.7, and all the values are similarly like that, with a 95% confidence. Uh, then we did some data analysis. We first conducted hypothesis testing just to compare the caries prevalence between the fluoridated and non-fluoridated areas. The null hypothesis suggested no significant difference, while the alternative hypothesis proposed that the fluoridated counties would show lower caries prevalence. For the age group 2 to 8 years, the Z value was negative 2.97. And for the age group 6 to 17, the Z value was negative 4.17. Both values corresponds to p-values of less than 0.05, which fall below the critical value of negative 1.96. This allows us to reject the null hypothesis in both the cases, indicating a statistically significant reduction in caries prevalence for fluoridated. Uh, I brought this table back just to show the confidence interval here. It's the same thing that I previously told you. Then we did some power analysis to ensure the sample size in this study was sufficient to detect a true effect. I conducted a power analysis using cohorts D. The effect size was 0.074 based on the mean DMFS of 1.9 for fluoridated counties and 2.2 for non-fluoridated counties, with a pooled standard deviation of 4.05. With a large sample size of about 7,497 for fluoridated and 5,107 for non-fluoridated counties, the statistical power was 99%, meaning the study is highly sensitive and can detect even small differences with a greater confidence. So, as we said, that community water fluoridation is a highly powerful tool for reducing dental caries, particularly amongst children. However, future efforts future efforts should focus on monitoring the potential risk for fluorosis and addressing fluoride levels in water systems. More studies are needed to evaluate how fluoridation affects underserved communities, ensuring that everyone benefits equally from this health measure. A limitation of this study is the reliance of secondary data, which doesn't capture the variation in individual fluoride exposure or regional practices. These were my references, and that's all. I hope I finished this one in time.
You did. I mean, you went like a few seconds over, so it was really good. So, all right, who has a question for Usman?
I got a really quick question, then I get out the way.
Yeah, go
Uh,
ahead, Michelle. I will be
What
taking that.
is, I don't know if you said this, but what is fluoridated areas and non-fluoridated areas? Is it economic, or is it race, or is it class?
So fluoridated areas are just those areas which have more than 75% fluoride in their water supplies. And non-fluoridated areas are more those areas which have less than 75% fluoridated, like water, fluoride in their water. Okay.
Okay.
And it's basically it the water is something like everybody's drinking it, right, with the tap water or school water fluoridation systems. So it's beyond any ethnic groups and any
Ah,
socioeconomic status,
okay.
whoever it is, it's gonna have fluoride. So unless
Yeah.
they are drinking water bottles, like the
Yeah.
the plastic bottles, so that's the only difference. Yeah,
Okay.
Anand.
Yeah.
Yeah. Anant, you can ask your question. Usman, if you stop sharing, and then
I'm so sorry. I'm so sorry.
no, you're fine. One of the
Uh,
things, it was interesting. Usman and I had this like whole conversation. I grew up in San Diego County. San Diego County is the largest county in the country that does not fluoridate their water,
Mm.
and there is a very high risk, at least when I was a kid, of like of bad teeth. But
hmm.
Anant, go ahead.
Hmm. Yeah.
Yeah, exactly. You are 100%, you are 100% true. So, water fluoridation actually, if it's more than 0.7 milligrams per liter in our water supply, like zero point 0.7 milligrams per liter in our water supply, it's going to
Mhm.
lead to different consequences like skeletal fluorosis, dental fluorosis. Being a dentist, I've seen a lot of cases of fluorosis. So this is very common and a very good question that you just asked me. So it's just that we need to monitor the fluoridation level in each county, that each water supplies areas, so that we can we don't have to overdose the population with that. Otherwise, they're gonna have fluorosis, which is gonna stain their teeth, and consequences after that. Right.
Just so people know, like one of the things Usman and I talked about, Chelsea, you can start sharing your screen. Was imagine you're living in a community like Flint, Michigan, and you're not drinking tap water, which is where you get your fluoride from, and you're drinking bottled water. What is that problem going to be? Now, we are very lucky nowadays that a lot of toothpaste does have fluoride in it,
Mm-hmm.
but not all does, especially children's toothpaste. So, so like I know my kids have to, one of my children get cavities very easily and is required to do fluoride mouthwash every night. So yeah, so it is going to be a big problem, and not the you brought up like probably the best question. If you have a federal appointment that says this is bad and bans it, yeah, we're kind of screwed. So, all right, Chelsea, you're up.
Yeah, I have so many opinions about, yeah. Okay. Um,
It's good. This is good. We're having good questions.
yeah, especially because I'm like, ooh, I want to be able to present an argument for my crazy relatives. Okay. Um, I might have we begun the timer? Yes. Okay. Hi, my name is Chelsea Dare, and I'm going to be talking about tuberculosis in the US among new arrivals. And these are mainly people who are here that were not born in the United States. So tuberculosis is an airborne disease that is caused by the bacterium Mycobacterium tuberculosis, and it typically affects the lungs, which is the first infection site. It is an airborne disease. TB can also affect the brain, kidneys, and spine, and other parts of the body, and sometimes can affect multiple sites in the body at once. So even though it's we think of lungs only, it's not only the lungs. It is speculated that TB is the leading cause of death from a single infectious agent after COVID-19. And though it has been in the decline for the past 27 years in the United States, it continues to be an ongoing problem because approximately 10.6 million cases were reported worldwide in 2022. Contrasting with that, within the same year, there were only 8,331 cases of tuberculosis in the United States. Tuberculosis decreased significantly in 2020 during the COVID-19 pandemic, but it has been increasing in numbers since then, particularly in 2021 and 2022. However, these numbers are lower than before the pandemic. There's two related conditions with tuberculosis: active TB and latent TB. Latent or active TB has no symptoms because there's a small amount of the infectious agent in the body. The person is not infected. However, this can change, and that can leading to active tuberculosis that is, again, highly contagious. There are many risk factors for TB, including HIV status, incarceration, and country of origin. And today we'll be looking at the risk factor of country of origin, specifically US born and non-US born. So I got my data from the CDC, particularly the Online Tuberculosis Information System, or OTIS. It was created and managed by the CDC, and data that was here was from a national surveillance system that requires all local and state public health departments to report TB. One of the limitations of the surveillance system is that latent TB or inactive TB is not tracked at this time. Okay, let me see. Okay, this is data that was found for active TB cases from 2018 to 2022. Oops, pardon me. Of note is that you can see that the numbers in each group remains fairly consistent. For example, in 2018, among US-born patients, there was 2,142 active cases. And then in 2022, the number rose significantly, but it still was at 2,642 cases compared to the cases among non-US born, which was 6,352 cases in that year. So just by looking at this graph, there seems to be a significant difference. I did some data analysis, and I apologize because I have a tenuous grasp of this, to see if the number that we could see visually is actually statistically significant. Among the non-US born, the total number of cases was 29,637 with a mean of 5,927.4 and a standard deviation of 531.43. In the US born, the total was 11,486 with a mean of 2,297.2 and a standard deviation of 268.5. With a 95% confidence interval, and with the standard difference of error of 3.98, we rejected the null hypothesis because the difference in value was greater than 1.96 at 2.48. In conclusion, I think this data really points to how we need to tailor targeted public health interventions for specific groups that are at risk, including those who are newly arrived to the United States. And we also need to increase surveillance for latent TB. The issue being that people can develop active TB after arriving to the United States and or excuse me, not follow through on treatment to it, or the latent TB can develop into active TB even years after arrival. Excuse me, those are my resources.
Great job. Perfect timing.
Yep. Oh, perfect. Great. Thank you.
No, you did a really good job. Like,
And those are my resources. I can't, the CDC is awesome.
yes, I concur.
And I
Right
used, yeah,
now.
four of my resources were through the CDC. So including, I found stuff on the Chicago public health website that was actually from the CDC. So
Yeah. All right. Question for Chelsea and TB.
I do have a comment. Is it okay to comment real quick?
Comment, but I would like a question from you,
Okay.
Yana, please.
Well, the question is, so I noticed that I remember you talked about when you first started presenting that there's a misconception of who's bringing TB over to the U.S. and the foreigners are bringing TB, but what are the socioeconomic factors contributing to that? Are we able to contribute finances to mitigate TB? We may have the finances, but Americans do not want to contribute those finances, especially if it's not an American. But the Americans were never, contributing or paying attention much to TB. So I guess my question is, what are the socioeconomic factors contributing to this high level of TB amongst non-American Americans?
And Chelsea, while you're answering it, Yana, do you mind getting your presentation ready as you're
I'm going to
listening?
stop sharing. Yeah, I thank you so much for asking that question because honestly, I wanted to present something completely different because I have read some research that postulates that many of the issue is inactive TB or latent TB, which isn't infectious. Versus, it's not active TB. But there isn't, and that's why I mentioned like we need a national surveillance system for latent tuberculosis. I think I can't speak to the socioeconomic factors in so much so that there's just the prevalence is so high worldwide versus in the United States. And current programs definitely do have partnerships with other countries. People who are immigrating here must test for tuberculosis. And then if they have latent TB or you can spot it in an X-ray, there's further treatment. I have a good friend who's from Morocco who had to do that. So it definitely has to be a worldwide effort because we can have tuberculosis down to 10 cases here. But if it's so prevalent everywhere else, especially with how often so many people travel, it's really important to include other countries.
Absolutely.
I didn't study enough about how other countries prevent and treat and screen tuberculosis, but yeah.
Yeah.
That was great.
Thanks, Chelsea. That was a really good question, Yana. All right, you're up.
All right. Are you able to see my screen?
Yes, we can. It looks great.
I'm ready. Good evening, everyone. I'm Yana Raymond, and my study focuses on the relationship between income and maternal mortality rates in the United States, and I'm looking specifically at the time 2020 to 2021. Amongst its peer-developed countries, the United States has the highest maternal mortality rate despite its technological and healthcare advancements. In 2021, the United States experienced a dramatic increase in maternal mortality rates and reaching 32.9 deaths per 100,000 live births. In most recent data, 2020 from 2022, now shows that maternal mortality rates have decreased to 22.3 deaths per 100,000 live births. Amongst all racial groups, however, Black Americans had the highest maternal mortality rates in both 2020 and in 2021. And this trend still continues even to today. Data was collected from the US Census Bureau and the CDC, the National Center for Health Statistics. The preliminary analysis of maternal mortality rates for the 31 states that did have information available for me to use showed that California and Illinois, in the far left-hand corner there, had the lowest maternal mortality rates, while southern states like Kentucky and Arkansas, far right-hand side, had the highest maternal mortality rates, nearly 40 deaths per 100,000 live births. Other preliminary analysis of household income showed that southern states like, again, Mississippi and Louisiana on the far left had the lowest household incomes for Black Americans, and states like California and New Jersey on the far right had the highest household incomes for Black Americans. However, the median Black American household income was far less, almost half the amount of that of non-Hispanic, their non-Hispanic white counterparts. I previously presented analysis on 2 confidence intervals and 2 hypothesis testing. However, today I'm demonstrating a regression analysis looking at the relationship again between maternal mortality and income. This figure represents the relationship between maternal mortality in 2020, which is the independent variable, and household income in 2020, which is the dependent variable. Notate that notate that negative relationship. It's not a significant, well, it's not a visually big negative relationship, but I'll discuss the significance and the numbers after. As income decreases, you'll notice that maternal mortality rates increase. This slide, this figure shows a nearly identical relationship, but this is for 2021. Again, the same thing. As income decreases, maternal mortality rates increases. So the less money you have, the more likely that you will experience maternal mortality. This is visually a lot here, but this is my calculations, the steps I took to find the correlation coefficient between income and maternal mortality rates for each year. I found the mean mortality rate for each year, the variance for state mortality, the mean household income for each race, the variance of household income for each race, the covariance for each race by year, and then the correlation coefficient for each race by year. These are just the steps I took, again, to find the relationship between income and maternal mortality. And so my results showed that all races had a negative correlation coefficient between negative 0.40 and negative 0.65. While these numbers are not close to -1, the author of our textbook, Sullivan, says that in practice, meaningful correlations, i.e. correlations that are clinically or practically important, can be as small as 0.4 or -0.4 for positive or negative associations. So it may not look like a lot, but it is significant, and it does show there is a correlation, a negative correlation between those 2 variables. Surprising, you'll see that non-Hispanic whites had the most negative correlation coefficient between 2020 and 2021, and Asians had the least negative correlation coefficient. And I think this is because there was some data that was not available for me, which may have skewed the results that I have. But I do highly believe that if everything was given to me, perhaps Black Americans would have a higher negative correlation. In conclusion, to improve on this analysis, I can perform calculations to estimate the equation of the regression line. There are steps available to do that, but it does take a little bit more work, which may not have the time to do. And that equation will best describe the relationship between income and maternal mortality, make predictions, which are not set in stones, but they are predictions that can help us determine the trajectory of maternal mortality. The limitations I had was data available to me from CDC, and also customizing data from the U.S. Census was not available to me. Here are my references, and thank you.
Again, perfect timing. I was just about to go. All right, question.
Yana, for like, were you able to find any data where you could find the most negative correlation with African American in women, like in cities that were predominant that have large African American populations, or does like a city like Chicago differ from a city of of similar size that does not have as large of proportion of African American women?
Well, the states that had the highest maternal mortality rates also have the highest percentage of Black Americans. So, I mean, you can kind of put two and two together that, and those southern states also had a lower median household incomes for all races. And Black Americans had the lowest median household income amongst all the races. So it's a double disadvantage to be in a state that had high maternal mortality and to be Black with low income.
Yeah. And I'm also thinking about the recent hospital closures on the south side of Chicago. Like, I'm just wondering how available is medical care,
Yeah, that's true. And sometimes data is skewed if we have a population of a population that has really high, for example, high mortality, white maternal mortality may be high in Evanston, maybe low in Evanston, but very high on the south side. It may skew the data that's presented, making it seem like, Illinois is okay. So that's something to consider, how high and how low is each race's maternal mortality rate. So yeah.
Yeah, it would be interesting to see what the range is in those areas. Yeah, great. This is great. It sucks. Alex, you're next. Not your presentation, it sucks, but the data sucks. I mean, it's just awful.
It's such a good presentation because we know how bad the data is, or the issue is.
Absolutely.
All right, go ahead, Alex.
All right. You can see my screen, right? It looks
Yes.
like you can see it, but just want to make sure. Okay.
Yes, we can.
All right. Give me 1 second.
Yeah, you're full screen now.
Okay, sounds good. So hi guys, my name is Alexis. I'm gonna be presenting my topic is about the obesity in Latino communities, and today I'm gonna be talking about not so much working with statistics involving obesity itself, but risk factors that correlate to increase in obesity rates and are obviously have negative correlation with obesity in Latino communities. Mainly education. So why does this matter? Latinos are the largest minority group in the United States, and they are the fastest growing minority group as well. Obesity has a prevalence of over 50% within this population, and there's a consistent evidence pretty much across all ethnicities and races that education and income are correlated. So higher education equals higher income, and then also obesity and overall health education are correlated as well. So if you have higher attainment of education, you generally have a higher health statistics, better BMI, better access to healthcare, and then vice versa for the other side of the scale. And then this is mostly relevant in Latino communities because Latinos are at higher risk for lower education attainment compared to other population groups. I'm trying to switch to my next other. So backgrounds and methods. I obtained this data from the U.S. Census Bureau, which was most recently conducted in 2020, the decennial census that was conducted. And you know how the census works. They send out a survey. Here's a basic plan of how the survey is conducted. And then using that survey, I was able to create a table where I was able to allocate two different age groups based on age and sex compared to their education attainment. I just chose these two age groups because the table provided to me was all the way up to 74. And usually there's like more data showing that people who are younger usually go to school more often, and then it's kind of hard to track high school graduation rates when they're out of high school for a long time. So going into my table right here, you can see 5 different columns, which basically show the proportion of people that have attained this certain degree. And then on the left side, you can see the different Hispanic groups that we are broken up into, where we can see both sexes and the totals for the entire table, and then we can go down into males and females and their respective age groups, as well as the average and standard deviation for those groups provided above it. And then here you can see it in a bar graph form. You can see the totals and the keys on the side right there. And this is really interesting when you really take a look at it for a longer period of time and you start to notice the subtle differences and the kind of trends that you can begin to make, are like kind of out of the scope of this presentation. But here you can see the overall trend that is following, which seems to not be a lot of higher education attainment within this population group that we obtained from the census. And then with this data, we are able to form confidence intervals using the standard deviation and means that we prepared earlier in table 1. And then here in table 2, we can see the confidence intervals that were constructed, breaking down the two hypotheses that we're going to test. And with those hypotheses, we can see the two groups that are going to be compared within each one. So males 18 to 24 and females 18 to 24, and if there's a statistical significant difference in their education attainment of high school diplomas, and then we can see the second age group of males and females in their attainment of bachelor degrees. And both of these were conducted at a 95% confidence interval. And then going down into our hypothesis, we're basically testing if our HO would be if there is no significant difference in educational attainment by gender. And then H1 for our high school diplomas would be that males have a greater statistical significance of achieving a high school education than females. And then, oh, sorry, I forgot to include our last one, but this table basically breaks down the hypothesis, and we also add in the bachelor degree one, where it's measuring the same hypothesis that we proposed in the first one, except that we are applying it to our second age group and the degree achievement above high school, which is a bachelor's degree. And then here we can see our data where we see our p value, and we end up rejecting HO for our high school age group, which means that males are at a greater advantage of attaining a high school degree. And then if we see the column, the row below it, we can see our bachelor's degrees hypothesis, where females are actually at a higher advantage of obtaining a bachelor's degree, and we reject our null hypothesis in both, which would be that there was no statistical significance, but we can see that there is based on our P and T values and our confidence intervals. And then for our power analysis, we conducted it an 80% value, and I calculated that we would need up to 5,200 individuals in total in order to get a data set where we could be 80% confident about rejecting our null hypothesis correctly. And this current sample set was over 9,000. So we would be well above the required power level that we needed. And I kind of
Uh,
got into the data discussion about what.
Alex, that's time. Sorry.
Okay, I'll stop sharing.
No, it's okay. You did a really good job, by the way, because you have so much data. All right, question. Zara, by the way, you're next. So some of you haven't asked a question, so you do need to ask a question, remember? It's part of your grade. Zahara, you can
My
start.
questions were on the box. It was okay to type the questions?
No, it wasn't. You actually have to ask
Oh,
it.
okay.
And it was only one question per person.
Mm.
So if, Marisol, if you
Alexis,
have a
if you
question.
wanted to say one more thing about your presentation, what would that be?
Yeah, go ahead, Chelsea. And that's fine. That's a legit question.
I guess I would say that the data provided by the census is really limiting, and honestly, the connection that I would be making with this data is weak at best, just because there is not a real control. There's nothing that the census is technically measuring except demographic data. So being able to draw the conclusion from obesity and like education level in this specific sample set would be a stretch, honestly, because I don't have enough data about their health status, income, any of that to kind of really draw firm conclusions on what I'd be wanting to prove to you guys.
Yeah, I think you would have to go into the community and actually do like survey data. So, all right,
Mhm.
Zahara, you're up.
Okay, can everybody hear me?
We can hear you perfectly and we see your slides perfectly.
Great. Let me test this out for a second. I don't want to.
Yeah, you're fine. Go ahead, you can test it. It changed.
Okay, cool. Okay. Hi, everyone. My name is Zahara. I'm here today to present on the topic of cultural competency in healthcare settings. Um, Cultural competency is the ability of healthcare providers to organize and organizations to effectively deliver services that meet social, cultural, and linguistic needs of patients. It involves understanding, respecting, and addressing the diverse cultural factors that influence health behaviors. I sought out to determine if cultural competency helps improve patient outcomes. To narrow my focus, I chose to look at patients diagnosed with diabetes, as it is a complex condition that requires a lot of interaction with your provider. I also looked at research that was conducted before and evaluated whether there was significant evidence to support my hypothesis. Through my research, I found that there were many studies designed to evaluate the idea of cultural competency. Many of the studies focused on patients rather than providers. The main study I decided to derive data from was a study conducted by Pagiao et al. The study evaluated patient attitudes towards cultural competence. The study mainly highlighted disparities between patients from various ethnic backgrounds. The research in this paper also highlights how people who do not speak English rarely receive information they can understand. In the reference study, the researchers used data collected from a survey conducted in 2017. This survey was one of its kind because it included questions on cultural competence. The data is openly available and can be downloaded, as I will show in the following slides. The study examines disparities in culturally competent care among adults with diabetes, and the results highlight significant disparities in cultural competency, particularly regarding the accessibility of health information. This is figure 2, and it demonstrates that non-English speakers were significantly less likely to report receiving information that they understand. I obtained the data from this website, and you can download extracts from here, and you can set different variables that you want to choose for the data set that you're trying to download. And I began by replicating their data collection methods. I created the extract and I selected for cultural competency questions, whether they were ever told they had diabetes, and demographic data. I filtered this data in Excel, and I started by comparing diabetes prevalence between men and women in the data set. So earlier I showed you a figure from their own set of data, and this is my data that I collected based on their methods. I calculated the difference that showed that there was about 4% of women and 4% of men had reported having diabetes, and the confidence interval at a 95 confidence level showed that there was no significant difference, meaning that the survey data was not biased towards one gender. And next, I analyzed data based on diabetes prevalence and age-based difference in diabetes prevalence. A two-sample t-test that's shown in table 3 evaluated two age groups, 20 through 39 and 40 through 60. Separate tests were conducted for men and women, and the p-value was less than 0.001, indicating a significant difference between those two age groups, meaning that one age group had a significantly higher level of diabetes, prevalence of diabetes than the other age group. I also conducted the Mann-Whitney U test, which calculates the difference in ranks between two groups, which is used to determine whether distribution of groups differs significantly. The Mann-Whitney test showed a U statistic of 7.54 million and a p-value of 0.7048. And this p-value shows that it is greater than 0.05, meaning we failed to reject the null hypothesis, suggesting that there is no statistically significant difference in diabetes prevalence between men and women. So that supported my earlier calculation. And then finally, there was a power analysis that I conducted to determine the adequacy of the data set for detecting meaningful differences in diabetes prevalence across groups. Using Cohen's d to estimate effect sizes for small, medium, and large effects. I was calculated at a 0.05 significance level with a desired power of 80%. The analysis showed that it would require 786 participants per group to detect a small effect, and then 88 participants for a medium effect, and 34 participants for a large effect. Given the number of respondents in the thousands, we can say that we're safe. In conclusion, this project explores the role of healthcare providers in cultural competence and management. And future work would be addressing cultural competency training for healthcare providers and incorporating more culturally tailored interventions and expanding languages services for non-English speaking patients. Additionally, to conduct future data analysis, we could explore long-term effects of cultural competency training on patient outcomes and investigate the role of other cultural factors such as religion, gender identity, and healthcare delivery. These efforts are crucial to reducing health disparities and improving diabetes care for diverse populations.
Zahara,
Thank you.
perfect timing. That was really
Thank you
good
so
job, by the way.
much.
No, it was great. Okay, questions. I know
Yeah.
Tiara has one in the chat, but I do want to give a chance to those that haven't asked an oral question yet first.
Yeah, I found this really interesting. Thank you so much.
Chelsea, you're cheating. You just asked one on the last one.
Okay. I just want to, in terms of like
Put it
how
in the chat. Put it in the
literacy is
chat.
so important. Okay, I will put it in.
All right. We have Maricela, Uzman, Iba, and Zubia. You ask a question.
Did the studies like talk about like any like screening programs to like identify like the high risk neighborhoods?
Yeah, so the participants in the survey data, they answered questions about their race, ethnicity, and it wasn't based like on neighborhoods or like a specific area. It was just randomly collected survey data. So whoever filled out the survey also addressed what like race and ethnicity they identified as, and then they split up the data based on race and ethnicity mostly. So they looked at African Americans, Hispanics, and Asian Americans. Only looked at those factors. They didn't really look at where people lived or um, other things like that. Just like basically basic demographic data, and then whether they answered these couple of questions about like their satisfaction on whether like their doctor was understanding, kind, or they understood the information that the doctor gave them.
Iba, start sharing your slides, please. And then Zahara, as Hiba's presenting, you can answer some of the questions from Tiara and Chelsea. Well, Chelsea's more of a comment, but yeah.
Okay.
You can answer them in the chat. They're really good questions, actually. All right,
Hello,
Hiba,
everyone.
see your screen. We got you. We're good. You're good to go.
Okay. So, hello, everyone. Today I'm presenting on gender disparity in e-cigarettes and vaping usage, analyzing recent trends at NEIU. So let's see the background. E-cigarettes are battery-powered devices that create smoke by heating liquid. It is said that it is less harmful than cigarettes, still have significant health risk, and research is going on its severity. Also, it includes exposure to nicotine and harmful chemicals like other chemicals which are hazardous to the body. It is non-commonly observed to be used in middle and high school students. Many of them believe that vaping is safe. In Illinois, legal age to buy e-cigarette is 21. To conduct this study is to analyze how much stricter regulation and better education on the risk of vaping is necessary to be implemented in Illinois. Uh, Coming to the methods, in this study, I used data from 2024 NEIU Student Health, Behavior, and Wellbeing Survey. This we received quantitative data through the cross-sectional study. The survey had 478 participants. To analyze the data, I did descriptive statistic to identify trends in e-cigarette use by gender. I analyzed data by power analysis, linear regression. Through them, you will get help to understand factors behind gender disparity in vaping behavior at NEIU. This data presentation to this table, it shows gender-based responses on e-cigarette. Here, yes indicates usage, while no indicates non-usage or non-users. As we can see from the table, 12.2% of female student reports using e-cigarettes, while 13.0% of male students report the same. Overall, 13% of all respondents use e-cigarette, while a significant majority of 86.8% do not use or they have not responded to the question. Next, let's take a look at bar chart, which represent clearly the proportion of e-cigarette users, that yes versus non-users, that is across gender respondents. The bar chart shows small difference between male and female in usage. So in data analysis, I perform power analysis. The objective is to determine the sample size needed to detect a significant difference in e-cigarettes usage between male and female students. Through power analysis, I found that we need about 2,700 participants in total to confidently detect a meaningful difference in e-cigarette use based on statistical rules. Whereas our study only has 523 participants. That's far fewer than what we need, making it nearly impossible to find any meaningful differences between the groups, even if they exist. Regression analysis, we wanted to see if gender and age influence whether someone uses e-cigarettes. To do this, we used a method that predict the likelihood of e-cigarette use based on factors. The analysis suggested that gender has extremely exaggerated impact on e-cigarette use, whereas according to present data, age has no impact. To summarize it, the prediction and conclusion from this analysis are unreliable. If we use this model to make decisions like any preventive program, we could be basing them on incorrect insight. In conclusion, the analysis didn't find significant gender difference in e-cigarette use at NEIU, but it set a foundation for future research. More data is needed to detect minor differences. In future, we should focus on increasing sample size to improve statistical power. Also, longitudinal studies and collaboration with other universities can expand the scope and provide deeper thoughts. And yeah, thank you. Also, I just want to share that we also have another survey going on in spring. I would say, please participate in the survey and ask your friends to participate in that survey so we can have like more collection of the data and it can help in, making more good policies for our school. Thank you.
Yeah, thanks, Eva. And I think thank you, by the way, saying about the other survey. It's really, really important people fill out these surveys. Yeah, Tiara asked if you have a link, so maybe you can share that in the chat. All right, question. Uzman or Zubia?
Yes, sir. I have a question.
Yeah, good, great.
Yeah. So, as you mentioned that e-cigarettes are bad than the cigarettes, or what do you think? E-cigarettes are bad or the normal cigarettes are bad? Because e-cigarettes also have those nicotines and other kind of chemicals. And I think, what do you think about this? Like,
Okay,
which
so
one is
I was reading
better?
one. Okay, yeah. While researching on this, I read one article. So it says that still we cannot conclude that like e-cigarettes are as hazardous as the normal cigarettes, but the research is going on. As of now, it is hazardous, not to that extent, but it is.
Yeah. Thanks, Hiba. Um, Samaya, you're up next, and you can load the slides. And again, Hiba, if you can, please respond to Tiara if you have a link to that survey.
I will do that. Okay, thank you.
Right. Samaya, you're next. And Zubia, you have to ask the question of Samaya, just so you know. And then
Um,
Hiba, you'll be asking a question of Zubia.
Hiba, can you
Okay.
please stop sharing your screen?
Hiba, you need to stop sharing
I
your
need help in this.
screen. Where the button green is?
Oh, I got it. I got it. Okay.
Yeah.
Is it
It's
fine
always
now?
difficult. It's not just you. I always have a problem, and I've been doing this for years. By the way, I love how organized your background is, Samaya, on your desktop. That's how it always should be. So go ahead.
Oh, thanks. Okay. Okay, so hi everyone, I'm Samaya, and the topic for my presentation is investigating health disparities of PM 2.5 pollution across the US. Okay, so PM 2.5 is a pollutant and it's mostly released from vehicular emissions and industrial emissions. From this figure here, we can see that it's really small in size in comparison with other cells and bacteria, so it can really easily enter our airways and bloodstream. And because of that, it's known to cause a lot of health problems like respiratory illness and heart disease. So a little bit of intro and significance. I chose this topic because I did my senior seminar during my undergrad on how PM 2.5 is linked to higher breast cancer incidence rates. And researchers basically found that PM 2.5 can change gene expression and it makes women more susceptible to breast cancer. So for this project, I chose to investigate PM 2.5 health disparities across US because I wanted to research from a public health perspective, along with all the statistical analysis I did throughout this project. So my central question was to investigate health disparities in PM 2.5 concentrations, and to do so, I looked at two Illinois counties. So these are the two Illinois counties that I examined. The first one is Kane, that's shown up here in that blue arrow. And then the second county was Sangamon County here in central Illinois. Our capital, Springfield, is also located in Sangamon County. So in 2023, Kane County had an annual average income of 125,000, and they had 91 days with above minimum PM 2.5 concentrations. And that's the data I got from Air Quality Index. And in 2023, Sangamon County had an average annual income of 75,000, and they had 255 days with above minimum PM 2.5 concentrations. So this graph here shows results from the information I got from AQI on the two counties. Basically, it shows how the lower income county, Sangamon County here, had more days of higher levels of PM 2.5 concentration compared to Kane County. So for hypothesis testing, I first stated my null and alternative hypothesis. My null was that there's no statistical difference between the proportion of days with above minimum PM 2.5 concentrations between Kane and Sangamon County. And my alternative hypothesis was that basically there is a statistical difference. So first, I calculated the confidence interval for both the counties, and these were my values. In other words, we can say that 1 in 4 days in Kane County had above minimum levels of PM 2.5, and in compared to Sangamon County, which had 2 out of 3 days with above minimum levels. And then I also did a two proportion z-test, and these are my results. This was my z-value, negative 12.56, and my p-value, which was also really small. So because the z-value is negative 12.56, it shows there is a significant difference between the two counties. And my p-value was also less than 0.001, so I rejected the null hypothesis. And I basically found that there is a statistically significant increased PM 2.5 exposure in the lower income county compared to the higher income county. And then I conducted a power analysis using the dichotomous outcome for two independent samples method. And my objective was to determine the sample size required to detect a statistically significant difference in the number of days with high PM 2.5 concentrations between Kane and Sangamon. And I basically set the power at 80%, meaning that there would be an 80% probability of rejecting the null hypothesis with a significance level of 5%. And I basically got 19.35, which I rounded up to 20 days. So basically, I found that I needed 20 days of observation for each county to be able to detect a statistically significant difference in the number of days with high PM 2.5 concentrations. So coming to my conclusion, I would want to explore why are we seeing this trend in Sangamon County and potentially explore other variables. I personally feel like there might be more industrial sources, emissions that are in Sangamon County compared to Kane County. And then, yeah, I would also want to compare that data with other Illinois counties. Two limitations I had was AQI data. It doesn't take into account other pollutants. So I would want to see if there's other air pollutants as well, or just PM 2.5. And then in regards with PM 2.5 concentrations, these are calculated using like very meticulous databases. So I feel like there's always a room for bias. And that's just what I was thinking about when I was doing my research. And that's my works cited. Thanks.
Great job, Samaya, as always. Zubia, question.
Yes. I just wanted to ask, we as general people, what can we do to not get exposed to the PM 2.5?
Well, the original study that I looked at, it basically said that women that are more like in metropolitan areas are exposed to higher levels of PM 2.5 sources. So I feel like you really can't do much like individually. It just kind of depends on the area that you're living at. And if you're living in a more like metropolitan area, you're just more prone to be exposed. But I mean, overall, it would be great if, we reduce industrial sources, we reduce fossil fuel burning. But again, I feel like that's really hard to achieve on like a individual basis.
By the way, just so you know, you can wear a face mask too. So if you have
Exactly.
it doesn't matter.
Oh, that's
In
interesting.
95, yeah, Yana put this
Yeah.
in. So it is actually the particles are large enough to be blocked by them.
Oh,
Um,
okay.
so it is interesting because during COVID, we were seeing less people, with that have asthma in those areas having asthma attacks because of that.
So Maya, I wanted to ask you,
No,
the data
Hiba,
you have.
no, no, Hiba, you gotta ask Zubia.
Oh, okay.
Yeah, and then Tiara and Chelsea had some comments and questions in the chat. So if you can stop sharing, Samaya and Zubia, you share your slides. And if Samaya, you can maybe answer some of their questions in the chat or through the discussion. But great job. Zubia, you're up. All right.
Can you guys see the screen?
Yes, we can. We can see the obesity images, which are always very scary. Go ahead.
I am not able. Okay, yeah.
You can go to full screen too by present. There you go. Awesome. You're in
Okay.
full screen.
Hello, everyone. I am Zubia Zainab, and for today's presentation, I did more detailed project on obesity in American young adults. So, for introduction and the importance of research, I am investigating the rise in obesity and overweight cases. This is important because obesity is a serious health concern that significantly increases the risk of the life-threatening conditions like heart diseases, diabetes, and certain types of cancers as well. It affects people of all ages and places a massive burden on individuals, families, and also healthcare systems worldwide. So considering for this project, I am specifically considering the genders and ethnicity. So considering the gender and ethnicity in obesity studies is crucial because different genders and ethnic groups experience varying rates of obesity and related health conditions. Men and women have different body compositions and metabolic rates and the genetic factors that can vary among the ethnic group and can affect obesity prevalence and health outcomes. For the data discussion, the information I took was from the article Trends in Obesity Among Young Adults in United States, and it did the research in the years 2005 to 2014, and the study involved people of around 5,455 adults, among which 2,638 were men of mean age 46 years, and the women were 2,817 with a mean age of 48 years. And this information was taken from for the two recent years, and they did surveys for the year 2013 and 2014. For the data presentation, there is okay. I took consideration of men and women of ages 20 to 39 years old as I was majorly focusing on young adults. They also had information about people above 39 years and up till more than 60 years. So for this, based on the data from table 1 and the graph, we can see that non-Hispanic white men aged 20 to 39 have the highest number of obese individuals, and the total number of men are a little more when compared to the women. And when we see the non-Hispanic white young adults are of higher range when compared to the non-Hispanic Asians and when compared to the Hispanic people. And then you can also see the graphs which are stating the same. For the data analysis, I did the confidence intervals for non-Hispanic white men and Hispanic men. I got the results for the confidence intervals, and this confidence intervals for the two groups highlights the disparities in obesity rates. The non-Hispanic white group shows a higher proportion of obesity when compared to the Hispanic groups. And then for the hypothesis testing, the Z-test confirmed that there is a significant difference in the obesity rates between the non-Hispanic white and Hispanic men, which is underscoring the need for the targeted interventions. For the conclusions, to improve the analysis, we can include more variables like the physical factors, doing longitudinal tests or track changes over time. There are also other factors such as environmental factors, mental factors, or physical factors which can be taken into consideration, and geographic factors as well. And the limitations of the data majorly includes that it was a cross-sectional design and it was relied on self-reported information and it focused majorly on a specific group. So we can for sure not take all the population into consideration, but we can take most of the population comparing from children to people of older ages just to make sure we are comparing all the people in common. Thank you.
Thank you so much, Zubia. All right, Hiba, please ask Zubia a question.
Okay, I wanted to ask you that while you were doing this research, what specific health risk you found that is associated with obesity in children versus adults?
Okay, when we compare it from children to adults, for adults, it's majorly the cardiovascular diseases as we see, and there are also cancers which can affect children more. Mm, in comparison to, they're majorly same when compared in children and adults because when your body is gaining weight, it's majorly the same thing until and unless you are doing some intervention for it. They're majorly they actually there are heart diseases. There are
I have a question coming in my mind,
some
like,
type of cancers which I am not able to hear you.
okay, yeah, sorry. No, I'm just thinking like, maybe any other student can also answer on this. Is the hypertension also seen in children?
It's scary. I can answer that question. It's we're seeing it much more in preteen age years nowadays.
And it could be due to like obesity or like genetic.
No, it's obesity.
Okay.
It's children that are morbidly obese. So BMI
Okay.
of above 30. And it's even higher than that. We're talking like more like above 50, which
Oh,
is
okay.
really, really horrid. Um, yeah, Tiara made a really, really good comment and question about like you can say it out loud now. This was our last presentation, so um, what were you saying,
Oh,
Tiara?
Zubia, I wanted to know, like, do you believe like apps like Uber Eats and DoorDash contribute to obesity when it comes to like easy access to food and college students, really depending on what type of college student you is, really can't afford to eat healthier. So each university has a benefit navigator that's supposed to help students access resources like SNAP. Do you think this would be helpful in decreasing like obesity rates? Because this is a bill that was passed last year. And when I was doing research on it, I wasn't able to contact the benefits navigator for our campus and most Illinois university campuses. And like with this bill, do you think it would be helpful if it was actually like implemented and the benefits navigator also pointed out resources like workshops so students would know like what type of food they would be able to eat and buy to help them, decrease the rate.
We do have our university which is I guess does giveaways of fruits and stuff. But then yeah, the all the apps and stuff, yes, they are one of the major causes doing it because the way you said, we have easy access to all the things, and then we don't want to do stuff on our own, and then we just get stuff. The DoorDash, we get everything in hand, so we don't do workouts, we don't make our own food. So, firstly, it's not healthy. Secondly, we are not doing any workouts. We're not even when we cook, we do some sort of movement, and if we are not even cooking for ourselves, it's like we are getting away from that movement as well.
Yeah.
And oh, okay, never mind.
No, you're fine. You guys can talk to each other later too. Yana, you had a comment or question, and then we'll end the final here. I just want to say one more comment before everybody leaves too.
Yeah, I was just going to mention something along the lines that Tiara said. Accessibility of food, but also the anxiety that some of these students experience, and mental health is an important thing. So people turn to food for comfort, and combination of that and other comorbidities. It's easy to gain weight, especially if like you're anxious and you're worried and you don't have access to things and you want to move fast and you're in a rush. So things to think about.
Yeah, that's a really good point. Yeah, there's a lot of studies in this area. So, by the way, but you guys did so much better. I really want you to sit back and reflect on your presentations now compared to they were during your first presentation. I know some of you had a lot of anxiety. We're talking about anxiety related to this course and all the work and all the expectations and how much how much I've pushed everybody. Um, I hope you realize that I did it with intentions that are good, and that maybe by now, at the end of the semester, you can reflect a little bit on what you've learned and where you've come. I mean, some of you have definitely picked up more of the mathematics than others. That's fine. That happens. But I think every one of you have improved dramatically in your ability to present complex materials and to do data analysis. So you should all be very proud of yourselves. Um, Again, it's okay that some of you improved way more than others. That's normal, but you should still be proud when you see improvement. So please, please sit back and reflect. I really hope everybody has a great winter break. It is a long winter break for us. We're not back until the 22nd or the 21st. So I'm very proud of everybody. I just want you to know that. I will be grading the projects tomorrow. Please get them in. Get anything else that's missing in. I need everything in. I will tell you, my wife's in the hospital now because of everything that's going on to her. So we're back at the hospital all the time. So I need the stuff in so I can grade, so I can spend every bit of time I have with her. So Zahara, did you have a question?
Oh yeah. So I you said submit everything that's missing. I can submit the extra credit.
Yeah, please submit the extra credit too, because some
Yes.
of you have done
And
those extra credits. Okay.
yes. And I think the other thing is assignment 5 is due tomorrow.
Yes, please get that. Yeah, if you the sooner you get it in, the better. I'm grading them as I get them. So I've
Yeah,
already
I'll submit
graded
it
some
right now.
people.
I'm just wondering. I'll submit it right
Yeah.
now. I hope your wife feels better.
Oh, speaking of that, some of you wrote some really good essays and responses to the students. Um, oh, yes, you're not getting the extra credit for course evaluation. We did not get enough. Only 8 people did it. So I'm like, come on.
I'm
Every
so
time,
annoyed with
every
that.
year. I probably still will give people, I will give everybody some extra credit a little bit. Um, yeah, if you still want to, only one person sent me the essay that they have for next time I teach this course. So please, if you're willing to share, it'd be so nice to share your advice for the next time I teach this course. Um, think about what information you would have liked to have known to help you prepare better for taking this course. Okay? No, you can't give me permission. You actually have to send me an email with it as a separate document. Sorry, Zara. It's very strict rules of how this works. All right. Hey, it was great to meet everybody. I know some of you I got to see more of others, but I'm around next semester. If you want to stop by, you're on campus. My door's open a lot. So just come and say hi, or you want to just see me, please do. I would love to see you. And if you have questions, always reach out. Bye, everyone. Be safe out there.
Well,
Okay,
I
and
hope
be
your
kind
wife
to
feels better
yourselves.
soon.
Yeah.
She will be.
Thank you so much. Bye, everybody.
Bye,
Bye.
everyone.